This is not the inflammation of the muscle. Ossification is okay, but this is a misnomer. But once the name comes in the literature, it always remains there. But the cause is not due to inflammation of the muscle. The condition that causes bone to form in the soft tissue, such as muscles, tendon, ligaments, or fascia. Most commonly, young active people and in athletes often cause by repeated trauma. We have seen myositis in the biceps, even in the deltoid, even in the calf muscle, but around the knee and around the elbow, most common in supracondylar fracture or any trauma to the elbow. Following supracondylar fracture, forceful range of motion exercise, especially when the child is referred to physiotherapy. Physiotherapy is both a physiotherapist in our country, not in India. Because they know, but in our physiotherapy, they will forcefully keep the movement, and even I have seen a mother doing forceful movement and causing myositis ossificans, severe myositis ossificans. So allow the child, don't send them to physiotherapist, and they can cause the myositis. So etiology, myositis ossificans is a reaction to the bruise in a muscle that has been injured. During the healing of the bruise, calcium can become deposited in the bruise, causing the hard bone-like structure. Bone-like structure, I say. This is not initially pure bone, but ultimately it remains the height becomes a hard bone. Types of myositis, non-hereditary myositis ossificans occurs after the trauma, and myositis ossificans progressive by degenerative disorder. Treatment in non-ossificant or the post-traumatic myositis, limiting the activity to rest the area, stretching gently, taking non-steroidal anti-inflammatory drug, NSAID. Indomethacin has got a good role, and you can prescribe indomethacin even in children. 25 milligram twice 12 hourly for 2-3 weeks without any agent. That limits myositis possibility. This was a case of undisplaced fracture and forceful exercise by local bone setter, and see that how this the bone is formed. We are discussing in the last lecture how to form the bone, but they are no expert. They can form bone very easily. So they finish the only moment. This was a case of supracondylar fracture treated conservatively followed by physiotherapy, type 2 fracture. And this is the result. The myositis is formed in the brachialis, I think even in the biceps also. So, what to do? Wait for a few weeks or few months. 9 months is not the goal now. You can exercise the myositis when it is mature, radiologically mature. There is a stop physiotherapy by others, only active movement. This was a case in the right side. You can see that this bone is from the humerus to the ulna, bony bar, and mature bony bar. When he came at 10 years of age, and then I exercise. But exercising myositis anteriorly is not very easy. You have to dissect very carefully. Sometimes you have to dissect the median nerve and brachial artery and mix the vein also. And very carefully you can dissect. Even complete resection is not necessary always. Otherwise you can injure the vessel and the nerve. So You can dissect a part and allow movement, usually it can be a movement. And the child, when it grows, it's go away. Here I have dissected fully, and it is in 2022. So, this is the movement of the resection, full movement. This was a case in 2003, I could not explain why this myositis is in such a state. When he came to me, this was a case of supracondylar fracture, and the myositis was significant, but the shape of the myositis is like a piece of bone, triangular bone. And this was the during the operation, this was the movement, this was during the resection. It looked like a piece of bone. This was the resection. And this is so these myositis can make bone. Was there restriction of elbow movement? Yeah. Previously I have shown the restriction of the elbow movement. Okay. This is 90. 10 degree to 90 degree. This was the X-ray. This was after resection. This was the fish. And he gained full movement. Usually, give a drain. When you are resecting myositis, give a drain and remove the tourniquet. See whether there is drain. If the hematoma is found again, it may again get into myositis. Because probably there is information in brain that it causes bone variability. And in a case of in adult, in head injury cases, there is more myositis in adults. But in children, I don't know. In children, they are after the head injury, is there myositis? So take home information in managing. Yes. No, somebody was telling that 9 months. But I usually don't wait for 9 months. 3 to 4 months. Wait, allow only active movement. Then on X-ray you will find that the bone, mature bone is there, not original bone. Steroid has got no role, no. Indomethacin, yes, it is in the literature that indomethacin has. And some of you may get worried about the nephrotoxic effect of the NSAID, but not in children. Children, if they prescribe indomethacin, 25 milligram, 12 hours, twice daily, 3-4 weeks, even months, no problem. So in managing supracondylar fracture, prevention of myositis is very important. Prevention is important. Don't send the patient to physiotherapist unless he is in your team. If the physiotherapist is in your team, he knows how to do the physiotherapy, who knows the consequence. Allow only active movement by child itself. It may take few weeks to get full range of motion. So we get previously in many cases, but I always teach that don't allow forceful movement after the supracondylar fracture or even any fracture around the elbow. Usually, আমরা তো এই যে কেয়ারগুলো করে এতবার কনজারভেটিভ ট্রিটমেন্ট করে 2 সপ্তাহ 3 সপ্তাহ করে ক্লাস করে রেফার টু ফিজিওথেরাপিস্ট ফর মুভমেন্ট তারপরে এই প্রবলেমটা শুরু হয় initially the child will gain few degree of movement, say 90 to 100 degrees. Allow the child to have active movement. Within 3-4 weeks, he will gain. Any question about the myositis? Supracondylar fracture is a separate issue. So, thank you very much. No problem in myositis.
So actually
or we just have few cases about myosarcoma videos. After that, just one case. You know, Doctor message about physiotherapy. So I'm going to show you work of one Indian physiotherapist. Okay, so this is a supramodular fracture. It presented after 2 weeks in this fracture. Yeah, rotated, maluniting. So I want to know from audience, if you get a supramodular fracture like this after 2 weeks, how many of you will try a close reduction? Close reduction. Anyone for open reduction? And how many of you will just leave it alone and probably you will do osteotomy later? So this patient went to a AO surgeon. AO is adult orthopedic surgeon, and a beautiful open reduction, KY fixation, everything was done. The child healed well. It's fantastic, but the elbow was stiff, completely stiff. But you don't see any myositis at this stage. But because the elbow was stiff, this patient was sent to a physiotherapist, and suddenly there was swelling in the elbow, and so this is a different myositis from a supracondylar fracture. Now you have capsular forearm fracture and myositis, and this is not in any muscle, it is in the bone. And then I believe that everyone in the crowd will say that don't do anything at this stage. Go slow. And we waited for everything to subside. Alkaline phosphatase came down. So I do alkaline phosphatase in 3 months' time. Alkaline phosphatase came down, but patient has severe restriction of progression and supination. So we went from posterior approach and exercise this completely. Then patient had good range of elbow and pronosoperation. So it's not just therapist in, it can happen anywhere. And myositis is something which is very common to children. One more input we have is if the child is skeletally mature, then we can give radiation when you exercise myositis. So we give, we give it for 3 weeks, twice a week for them. Use that. So I will go to the next topic, which is radioulnar synostosis. So how many of you have seen any case of radioulnar synostosis? Just raise your hands. So this makes sure that your supination is correct. A child with radioulnar synostosis will raise his hand like this, not like this. Because most of the time the radioulnar synostosis is in pronation. Any idea why is it in pronation? Why not supination? Absolutely fetal position. So basically there are 2 types of radioulnar synostosis, congenital and acquired. Acquired are mostly post-traumatic. The congenital ones are because of synostosis, and it is always proximal. Never, you don't have middle or distal. And this is how a forearm develops. It will develop by around 6 weeks like a forearm body. And then the radiation ulna ossification takes place and unzipping takes place. And this unzipping takes place from distal to proximal. And that's why you don't see distal synostosis, you will always see proximal synostosis. And always, whenever the unzipping occurs, the fetal position is in pronation. That's why the deformity is in pronation. You never see congenital radioulnar synostosis which is fixed in supination, right? There are 2 types.
If it occurs very early, then you will see type 1 synostosis, which is a synostosis which is there, but radial head is not affected. But if it happens later on, then you will also see affection of radial head. So it depends on when it occurs. Okay. Almost 80% are bilateral. So if the child is symptomatic on one side, other side may have lesser affection, but more positive in the other side, which is very important. Okay. Surprisingly, the parents, though it is congenital radioulnar, very rarely they will be diagnosed at birth, because many times it is not fully ossified, some movements are present, and because the functional limitation are less, the parents also don't notice. I treated a child recently with congenital radioulnar, and then I saw the father. The father also had congenital radioulnar, and neither the father's mother or father's wife had noticed that person had any problem. So this is something which is the activities which will catch attention are actually catching a ball. Okay, children cannot catch a ball, those who are playing cricket well, because one hand will be in pronation. Hand washing at school is a problem. Toilet cleaning is a problem for some of the children, because cleaning the back part requires the hand to go in supination, which is not possible. Okay, and swinging the racket all the time. So I always say that when the child goes to play cricket, that's the time it will be most commonly diagnosed, and it is more common in boys. So these are some of the deformities which are present in congenital radioulnar synostosis. Okay, additionally, some of the children may have loss of normal carrying angle because the joint is affected. Some of the children also may have flexion deformity of elbow, shortening of forearm, and hypermobility of radioulnar joint, because those are compensatory movements. Classification I'm not going to do, less difficult. Let's go to cases related. This is how I treat congenital radioulnar synostosis. So this is a 2.5-year-old child that has congenital radioulnar synostosis, which is bilateral. Okay, if you can see here, it is both sides, but right side is more affected because this is condition. So the first question is, at what age should we treat? At 2.5 years age, what should we do? Also, operate. How many of you will operate at 2.5 years? Observation. Hitesh, what is it? Observe. This was observed. Now, when the child became 4 years age, he had difficulty in supination and he came to school, and there was difficulty in eating. The child on the right side dominant and eating was a problem. Okay? And that time the parents said that they want surgery only for the right side. And then he also thought so we should do that. So what I do is I do a very simple operation. People have prescribed various operations, doing radius and ulnar osteotomy, doing osteotomy proximally, distally, a lot of operations are described. I do a very simple thing. What I do is first I pass an intramedullary K wire across the radius without doing any osteotomy. First I pass a wire. Then at mid shaft of radius, which is the most easily accessible part of the radius, I will take a small incision around 2 centimeters. I will go down to the radius. I will erase it from all over. I will remove the pronator teres attachment, and then I will drill multiple drill holes in the radius and do the osteotomy. Okay? Then on table we supinate the forearm, okay, to almost 40-degree supination, and I give above elbow plaster in 40-degree supination. Not in complete supination, 40-degree supination. And this plaster we keep for around 6 weeks and then remove the plaster. And then remove these wires at around 6 months. 40-degree supination, not complete supination. This is why there is always synostosis, you don't operate. So this is one of the conditions where you just take the forearm into functional position. You do not exercise the synostosis. If you exercise the synostosis, There is no functional benefit because there are no muscles in this child to cause chromosupination. So there are people who do a lot of things. There are things they have been described. But will it give rise to movements of chromosupination? No. So to doing osteotomy through synostosis proximally, it is dangerous to fix. It is difficult to fix. There are nerves around, you have posterior dorsal nerve. So it's difficult to do. So this is a very simple process. The proximal radius is not a very easy area to access. Middle forearm is a very, I think everybody in the audience will be able to do this operation. 40 degrees. Pronation. 80 degrees. Without osteotomizing ulna. And where is this ulnar deformity is getting corrected? I don't know. It's maybe inferior ulnar planning. It may be getting corrected by plastic deformation of ulna, but it will come very easily. Yes. So only right hand. I left the left hand just like that because there were no problems. So congenital radial synostosis, you will operate only if that's the functional problem.
Functional problem and it's causing a trouble. And now the scenario has changed. Everything now in laptop, mobile.
I will show you. I will show you the results of this. So right side was corrected. The parents came back after 6 years. That doctor, your right side has done very well. Everything good. Now we want surgery for left side. And I said, why do you want surgery for the left side? He said, now a child is having difficulty in toileting on the left side. So we said, okay, then we did the same procedure, passed a K-wire and passed a radial osteotomy. The difference is that in 4-year-old child, if you go to ulna osteotomy, it is optimal. In an older child, after 10 years, what I found it, if you don't do ulnar osteotomy, it does not correct. You can see that I have done also an additional ulnar osteotomy at proximal 1/3 distal 2/3 junction. Because again, that area is very accessible, and you don't fix ulnar. You fix only radius, okay? And then this. You can see that both hands are in functional position. He is able to eat with both the hands. 40. But again at 40 degree. So from 40 degree supination, it is easy to get the wrist down by just moving the shoulder. No, this was 30 degree position. Supination, 70 degree. 40 degree. But see, he is able to do everything. I hope this video works. He is able to eat. So this is 40 degree supination. What you see on lateral is happening from the shoulder. No. But he can pronate by moving the shoulder joint. And if you see him, I'll show you further video, you will not be able to get out. See, if there is a restriction of supination, you cannot put your elbow inside the chest. But if pronation is restricted, it is very easy to control. And this child is able to type, play piano, do everything. But the key is 40 degree supination. If you give 90 degree supination, it's a problem. If you do mid-prone, also it is under direction. The key is 40 degree. In radius. Because if you don't do that, the radius translates. The radius translates, and then it leads to non-linear, bowing, bad-looking deformity. So you need to control the radius translation by putting it down. On table is very simple. On table, raise the elbow, and if your hand is going to the mouth, that is the right position.
What is the problem?
More than 40? The pronation is a problem. Then child cannot write, cannot type. Right. So that was that time when they did study. Today's children requirement, this works for them. I'll show you further cases. To this child, I have seen this child from childhood and he said no surgery because he is doing well. He is come at 12 year age and you can see that he's got bilateral congenital radiolus synostosis, but the right side is in pronation. Yeah, the left side he comes to with prone, so left side nothing is required. His again problem is when he's eating, when he right side is dominant, this is how it goes. So he eats like that. And now he was finding it very awkward to do that. Plus he started having pain with the wrist child. Okay? So these are x-rays of this child. And then we did radial derotation. Again, same. Okay? Intramedullary wire. We did a radial osteotomy. And then we did additional again, same fixed target. Because when you have radiolus synostosis, necessarily it is a single bone foramen. You got stability at elbow through upper ulna. You have stability at wrist through lower radius. And they are both joined together. So if angle does not unite, it is okay. It's just don't bother to fix it. So this is on table. This is how it is set. The flexed elbow should go to the and this is the child after surgery. You can see that he is able to take his hand to the knob. I'll show you all other functions. He is able to wear the socks. This requires pronation. He is able to do it very well. All functions. Now you know this deformity is not visible. Okay? He will be able to eat spring roll which was served in the evening today with fork and knife without any problems. He is compensating at the shoulder joint very nicely. Tension. So somebody spoke about typing. He is able to shoulder, absolutely. But no one can notice it. If I am doing it, nobody will be able to notice. So, very simple management again for congenital radiolus. In children below 10 years, just a radial osteotomy. In children above 10 years, additional ulnar osteotomy. And you put them in plaster, no plates, small incision, cosmetic surgery, even for girls, this works very well. And you remove the wire after around 6 months. They didn't come to follow the first patient because I asked them why did you come for a follow-up? They said, doctor, if you would have come, you would have suggested other side surgery, so we didn't come. But when they wanted, they came. This is a very interesting case. This case fell down and had pain in the elbow joint. Okay? And this was treated at outstation around 500 kilometers from Bombay. And this was diagnosed by a very senior orthopedic surgeon as radial head dislocation. And in emergency they reduced it. Okay? Somehow they reduced whatever was done, and after reduction the patient lost, the elbow became locked. And for 3 months he did not have any elbow. Okay, so this is how the patient came to me. So diagnosis here is, of course there is radioulnar synostosis but with congenital radial head dislocation. Now what happens is till 10 or 11 years this is completely asymptomatic. After 8, 9 years or 10 years the radial head grows inside. And when it grows inside it gets locked. with flexion. So these children will have symptoms after 10 years. Where the, on flexion, the radial head will get locked over the lower humors. And the treatment here is excision. What is the most difficult part of the excision? Posterior introductions. And of course we investigate, but I take this incision.